guidelines were developed by the Provincial Neurosurgical Nurse Educator Network to document the processes associated with the basic assessment of a patient's neurological status. The guidelines provides direction for local development of bedside neurological observation protocols in order to ensure consistency of the neurological assessment within and across different organizations. For the individual patient, this provides a baseline from which changes in the patient's neurological status may be identified, reported, and managed in a timely manner. This video will review content related specifically to level of consciousness using the Glasgow Coma Scale, pupillary response, limb movement strength, and vital signs. Please note, these guidelines are for adult neurological assessments only. The Glasgow Coma Scale is an assessment scale developed by Teasdale and Jeanette, which provides a standardized measure of the patient's level of consciousness by observing the patient's behavior in response to a gradually increasing stimulus. This ranges from a less invasive stimulus, such as speaking to the patient, to the application of a painful stimulus, such as supraorbital pressure, in order to obtain a behavioral response. The scale contains 3 subscales: best eye-opening response, best verbal response, and best motor response. It has a collective maximum score of 15, indicating a fully alert and orientated person, and a minimum score of 3, indicating a comatose person. When approaching the patient, initiate conversation in a normal tone. If you do not elicit a response, gradually increase the tone of your voice. Follow this by light touch and then proceed with painful stimuli assessments. Please note, additional documentation related to neurological assessment should be included in the narrative notes. The placement of an asterisk or other institutional specific indicator on the neurological observation tool can be used to indicate that further documentation is included in the narrative notes. This should include documenting the stimuli used as a means of communicating to other healthcare providers that any noted changes are not merely due to different techniques. Patient's eyes open spontaneously with no prompting from the nurse as he or she approaches the patient. The patient receives a score of 4. Patient's eyes do not open spontaneously, but they do to a verbal stimulus.
Lauren, can you open your eyes?
Speak in a normal voice initially, and then in a louder voice as needed to consider hearing impairments, medications, and status fluctuations. Patient receives a score of 3.
Lauren, can you open your eyes for me? Lauren, open your eyes. You're just going to feel me put some pressure on your finger here, Lauren. Little squeeze.
Apply pressure with a pen or pencil to the lateral outer aspect of the proximal or distal interphalangeal joint. Apply painful stimulus for 10 to 15 seconds to elicit a response. The patient receives a score of 2.
Lauren, open your eyes. Lauren, can you open your eyes for me? You're going to feel me put some pressure on your finger here, Lauren.
A patient will receive a score of 1 if the eyes do not open. If eyes are closed by swelling or surgery and are unable to be opened, score 1 and indicate with a 1C or a C in the no response none section. If one eye is closed, document the response from the functioning eye. If the patient is unable to vocalize due to the presence of an endotracheal tube or tracheostomy, score 1 and indicate with a 1T or a T in the no response none section. Please note, if a patient is unable to vocalize due to the presence of an endotracheal tube or tracheostomy, but is able to communicate through the writing or mouthing of words, the response still receives a score of 1 indicating with a 1T or a T in the no response none section. In addition, a description of the patient's response should be described in the narrative notes. If the patient is able to verbalize despite the presence of a tracheostomy, enter a T in the appropriate section. If the patient has a language or communication barrier and there is no interpreter or family present at the time of the assessment, Document the language barrier across the section and expand in the narrative notes.
Good morning, Lauren. My name is Lisa, and I'm going to be your nurse today. I'm just going to ask you a few questions to complete my assessment.
Okay.
Can you state your full name for me, please?
Lauren Elizabeth Smith.
Good. And can you tell me where you are right now?
At the hospital.
Good. And how about the month?
It's July
And what year are we in?
2015.
Good.
This patient is orientated times 3 and will receive a score of 5.
Good morning, Lauren. Can you state your full name for me, please?
Lauren Elizabeth Smith.
Good. And can you tell me where you are right now?
I think I'm at church.
Okay. Can you tell me the month?
It's July
And how about the year?
2015.
Good.
This patient is confused and will receive a score of 4.
Good morning, Lauren. Can you state your full name for me, please?
Lauren Elizabeth Smith.
Good. And can you tell me where you are right now?
Have you seen my dog?
Would you be able to tell me the month and the year?
Oh, look, there's the cat and the dog.
This patient is using inappropriate words and will receive a score of 3.
Lauren, good morning. Can you open your eyes for me? Lauren, open your eyes. Lauren.
This patient is making incomprehensible sounds and will receive a score of 2.
Lauren, can you open your eyes for me? Lauren, open your eyes. Lauren, open your eyes.
This patient has no response and will receive a score of 1.
Good morning, Lauren. I'm just going to get you to squeeze my fingers. Squeeze, squeeze, squeeze. Good. Now let go. Good. Now show me your thumbs. Good.
This patient obeys commands and can be scored a 6. Please note it is not acceptable to ask a patient to squeeze one's hands unless he or she is also asked to release it. Hand grasping without a release may be merely a reflex. If the patient is unable to obey commands, place the patient in a supine position with hands placed at the groin area and proceed through the assessment by applying a painful central stimulus.
Lauren, can you open your eyes for me? Lauren. Lauren, squeeze my hand for me. Squeeze. You're going to feel me pinch your shoulder a little bit, Lauren.
This patient localizes to pain and will receive a score of 5. The patient purposefully moves a limb in attempt to locate and remove the source of the applied central painful stimulus. The hand must move toward the source in an attempt to remove the painful, noxious stimulus. An example of this is to the chin or across the midline of the body. If the patient is localizing with one arm and not moving anything else, document this as the best response. Trapezius twist. Using the thumb and 2 fingers as pincers, feel for the mass of the trapezius muscle located at the angle where the neck and the shoulder meet. Take hold of about 2 inches of the muscle and twist. Apply gradually increasing pressure for 10 to 20 seconds to elicit a response. Please note, high-level spinal cord injuries may interfere with the assessment using trapezius twist.
Lauren, can you open your eyes for me? Lauren, can you squeeze my hand for me, Lauren? Squeeze. Okay, you're going to feel me put some pressure on your eye here, Lauren. It's going to hurt.
This patient is showing flexion withdrawal and will receive a score of 4. Supraorbital pressure. Place the flat of the thumb on the supraorbital ridge. It is a small notch below the inner part of the eyebrow, while the hand rests on the head of the patient, gradually increasing pressure for 10 to 20 seconds to elicit a response. Please note, supraorbital pressure is not to be used with orbital, skull, facial fractures, or frontal craniotomies.
Lauren, can you open your eyes for me? Lauren, open your eyes. Lauren, can you squeeze my fingers? Squeeze. You're going to feel me put some pressure on your jaw here, Lauren.
This patient is showing abnormal flexion to pain, decorticate posturing, and will receive a score of 3. Jaw margin pressure. Place the flat of the thumb at the angle of the jaw at the maxilla-mandibular joint. Apply gradually increasing pressure for 10 to 20 seconds to elicit a response. Please note, apply with caution in patient with increased intracranial pressure, as this may increase ICP if venous return is compromised due to compression of jugular vein.
Lauren, open your eyes. Lauren, can you open your eyes for me? Lauren, squeeze my hand. Give me a squeeze. You're going to feel me pinch your shoulder a little bit.
This patient is showing extension to pain, decerebrate posturing, and will receive a score of 2.
Lauren, open your eyes. Lauren, can you open your eyes for me? Give my fingers a squeeze, Lauren, squeeze. You're going to feel me pinch your shoulder, Lauren.
This patient has no response to painful central stimuli and will receive a score of 1. Please note, sternal rub is not recommended due to potential for severe bruising and residual pain and discomfort.
Hi, Lauren. I'm just going to ask you some medical questions related to your eyes, okay?
Check the patient's baseline or history for any cataracts, surgeries, or dilating drops that will affect the assessment. Instruct the patient to look forward. If unconscious, the nurse is to open the patient's eyes by lifting the eyelids, looking for midline status. Use a concentrated light source, such as a pen light, ophthalmoscope, otoscope, or flashlight, in a dim room. Turn off ambient light to attain a response and assess for direct constriction. Move the light from the outer aspect of the eye inward toward the pupil. The pupil should constrict. Repeat for the other eye. Consensual constriction. Shine the light into one pupil and observe the other pupil for constriction. Repeat for the other eye. Please note, to assess motor strength and sensory function in the spinal cord injured or suspected spinal cord injured patient, use the spinal cord testing guidelines as per the American Spinal Injury Association. Limb muscle strength is tested to observe for any sign of asymmetry between limbs and may provide information about the possible anatomical location of any intracranial pathological process or dysfunction. In a patient who obeys commands, assess the patient's ability to move limbs against gravity and resistance in response to a command.
Hi, Lauren. I'm just going to get you to lift your arm up for me. Good. And I want you to pull against my arm. Pull. Good. And I want you to push.
Assess and document each limb separately. Observe for differences from side to side. Arms, assess for straight arm lift, elbow flexion, and extension.
Hi, Lauren. Can I just get you to hold your arms out for me? Now flip them over and bend at your elbows and right back down. Good.
Legs, assess for leg extension, plantar flexion, and dorsiflexion.
Okay. So can you straighten your legs out? Now bend your knees up, please. Good. Straighten back out. I want you to push against my hands. Push, push. Good. Pull. Excellent.
If the patient does not respond to commands, assess and document symmetry and strength of each unrestrained limb movement based on the assessment of motor function for GCS. An example of this is by observing a patient's spontaneous movements or patient's response to central pain. Document the best response of each limb separately on the neurological observation record. A number of different motor strength scales are being used depending on organizational preference. Here is an example of one such scale. Please note, if unable to assess strength movement of a limb due to a fracture, cast, traction, etc., document as non-applicable, and document reasoning in the narrative notes. Grade 5. Limb moves against full resistance. Grade 4. Limb movement against moderate resistance, but strength is diminished. Grade 3. Limb may move against minimal resistance or against gravity. Grade 2. Limb moves on a horizontal surface with the inability to lift against gravity. Grade 1. The limb or the muscle flickers. Grade 0. No movement is observed. For posturing, abnormal flexion to pain, document F for flexion. The arms flex at the elbow in response to painful central stimuli. Accompanying this movement is shoulder adduction, wrist flexion, and the making of a fist. Legs extend at the hips and knees. Extension to pain, document E for extension. The arms extend at the elbow in response to a painful central stimuli. Accompanying this movement is adduction of the shoulder, flexion of the wrist while the fingers either make a fist or extend. Legs extended with the toes pointed downwards. Obtain and document vital signs as per the neurological observation record or an equivalent patient care record. Changes in vital signs related to neurological deterioration are often a late sign of deterioration.